To our guests, it's good to see you and thank you for making the time. I am Councillor Marshall Katung and I chair the Scrutiny Board for Adult Health and Active Lifestyle, as you can see. And just to also say that if you've not had a drink and some fruit, you need fruit to keep you going, keep your sugar levels strong, because we've got a very lovely agenda today with all of you to hear. So please do fill up your bellies. Just to let you know that this meeting is being webcast on the council's website so that any interested members of the public or other stakeholders who are unable to observe in person can still observe remotely. So this meeting recording will also be available on the council's website after today's meeting. I will now invite members of the board to kindly introduce themselves, and please could you kindly unmute yourself after you have introduced yourself, and I will start with Councillor Anderson.
Thank you, Chair. Good afternoon, everyone. I'm Councillor Caroline Anderson. I represent Adlin Wharfdale Ward.
Thank you.
Good afternoon. I'm John Beale. I'm Chair of Health Watch Leeds, and I'm a co-opted member of this board.
Good afternoon, I'm Sharon Burke and I represent Middleton Park Ward.
Good afternoon, everyone. Councillor James Gibson, Crossgates and Winmore Ward.
Okay, good afternoon. I'm Luke Farley, Labour representative for Bermondsey and Richmond Hill.
Good afternoon, everybody. Councillor Mohammed Iqbal for Hunslet and Riverside Ward.
Good afternoon, everyone. I'm Councillor Taylor and I represent Chapel Allerton Ward.
Good afternoon, Councillor Eleanor Thompson from Guiseley and Rawdon Ward.
Good afternoon, Councillor Harrington from Wetherby Ward.
Good afternoon, everybody. I'm Angela Brogden, Principal Scrutiny Advisor.
Good afternoon, Toby Russell, Clerk to the Scrutiny Board.
Thank you very much, board members. I would now move to the formal meeting agenda, and I would kindly ask Toby to go through agenda items number 1 to 5 for us.
Thank you, Chair. Under agenda item number 1, there are no appeals against the refusal of inspection of documents. Under item number 2, there are no items which would exclude the press or the public. Under item number 3, late items. So there's been supplementary information that has been provided to the board in relation to agenda item number 11. This is Appendix 2 of the report, which is a summary of the Scrutiny Board's working group meeting held on the 9th of March 2023, and it's regarding the Leeds mental health strategy. Under agenda item number 4, can I ask members to declare any interests? Thank you. And under agenda item number 5, apologies have been received from Councillor Kidger and Councillor Hartbrook. Thank you, Chair.
Thank you very much, Toby. Agenda item number 6, minutes of the last meeting, which was held on the 17th of January 2023. Could I ask members if you've got any matters arising from that? Sorry, 21st of March. Of February, I'm sorry. 21st of February 2023. Could we approve that as the correct records of the minutes? Is that a nod from all of us? Thank you very much. Okay. Agenda item number 7, and that's the Leeds Committee of the West Yorkshire ICB update. So since July of 2021, this Scrutiny Board has been actively monitoring the ongoing development of the new local integrated care system. And during our last update in October last year, we agreed that today's meeting would be more focused on the key priority work areas of the ICB in Leeds linked to the Health Leeds plan. On that basis, board members have been provided with an update report from the ICB Accountable Officer for Leeds, Tim Riley. Unfortunately, Tim cannot be with us today, but he has sent his able representatives who would be speaking and giving us an update on the report today. So I will now invite all the participants on this agenda to kindly introduce themselves, please.
Hi, I'm Jenny Cook. I'm the Director of Population Health Planning for the ICB in Leeds.
Good afternoon, Gaynor Connor, Director of Primary Care and Same Day Response for the ICB in Leeds.
Tony?
Yeah, hi, Tony Cook, Chief Officer, Health Partnerships. Thank you.
And Tim Fielding, Deputy Director of Public Health. I'm here deputising for Victoria Eaton, DPH, today, so not specifically for this item, but for the duration of the meeting.
Thank you all for coming. I will now call on Jenny. Jenny, I believe you will be giving us a brief report.
Yes, I'm going to talk through briefly the first two items, then hand over to Gaynor to do an update around improving access to general practice. So included within the paper, we've provided an update around our refresh of the Healthy Leeds plan. This links nicely to the other agenda item because this is the Healthy Leeds plan is effectively the health and care partnerships response to the health and wellbeing strategy. So focusing specifically on the actions that the health and care partnership can take. The original Healthy Leeds plan, which was named the Left Shift Blueprint, was developed a number of years ago, and that was during COVID as well. So it felt really timely and really important to refresh the Healthy Leeds plan. Part of the need to do the refresh was to be much more specific and directive around a core number of strategic indicators. Some of the feedback we've had around the plan to date is it hasn't always allowed us to effectively prioritise resource and prioritise energy in the city. And so although we haven't completed the refresh, we wanted to provide Scrutiny with an update around the process and where we were at with that. So I'm happy to answer any questions around that. We've also included within the pack a bit of an update around how we deployed the health inequalities funding in 22-23. So nationally, there was money available to ICBs across the country around the core 20+5 framework, which is a national framework which focuses on a number of key conditions for those in the 20% most deprived in the country. In West Yorkshire, we made a specific focus that would actually be around the 10% most deprived, because that represents in Leeds 26% of the population, so much more targeted. And when the funding was announced last year, it went to West Yorkshire, and then West Yorkshire delegated a further portion to Leeds, and that was equivalent of just over £3 million for Leeds. At the time, there was a bit of uncertainty about whether that funding would be made recurrent or not. So what we wanted to do is deploy that funding as quickly as possible around areas of work where we knew we could make a difference. So we want to target that money as locally as possible with the community around specific areas where we could see improvement. So that included 44 individual projects that were selected from a long list of 90 proposed ideas. So there's a lot of enthusiasm and a lot of ideas about how this funding could be used to tackle health inequalities. The majority of those projects got up and running really quickly and established throughout the year. There was a small number that didn't progress as planned, and that was largely around recruitment. But overall, actually, considering how quickly the funding was issued, those schemes were mobilised really, really quickly. Provided a little case study in there around the hypertension project as just an example of how a small amount of funding with some really targeted effort could make a difference to quite a large population. We've had confirmation that that funding has been made available for next year. And we're going to be having some conversations this week about how we start to deploy that funding in a more recurrent basis. We used a large portion of the funding to develop a community grants response, so working with very small third sector organisations across Leeds. Actually, that's where we've seen some of the most kind of exciting and intuitive projects. We want to be able to continue that. So just a bit of a snapshot around health inequalities funding and how we want to use that in the future. And then the last bit from me was just around the intermediate care redesign programme. So this has been a really significant priority programme of work for the city. It links to probably lots of the updates you've had in the past at Scrutiny about some of the challenges in the hospital and system floor, and the need to tackle that in a much more strategic and long-term way. We set the programme out over 3 phases. So the initial phase was around a diagnostic. So do we really understand the challenges in our current intermediate care provision? And that took place from September, October, November last year. We then, recognising that actually winter, December, January would be quite a difficult time to launch a significant transformation programme. We had phase 2, which was about quick wins. So what are the short-term things that we can do to improve flow and set us up for a longer-term transformation? And they included some really great projects around things like length of stay in our community beds. So really driving down that length of stay and improving productivity to get people home quicker, looking at our transfer of care arrangements and some of the trusted assessor models. So there's been some really valuable quick wins from that process. And we're now ready to move into that full implementation phase, which is about a really significant redesign of our intermediate care services across Leeds, which will happen really over the next 18 months. And that includes everything from that kind of admissions avoidance to how we help people to stay well at home and avoid crisis and avoid going into hospital, to how we, once somebody's in hospital, that we make transfer of care decisions really quickly and support people to get home, and the reablement offer that people receive when they're at home to help them get better, and the community care bed offer as well. So what's the scope and scale of the number of community care beds that we have in Leeds? Part of our diagnostic told us that we have an over-reliance on beds and a high number of community care beds, and actually we could send people home quicker with a different package of support. So it's going to be one of the biggest and most significant transformation programmes in Leeds. We've got a project team that represents the full partnership. So the SRO for the project is Phil Wood from the Teaching Hospital, and a programme team made up of partners across the city as well. And we'll be able to provide more detailed updates over the coming months if that's something that Scrutiny would like to have. Over to you, Gaynor.
Thank you very much, Jenny. Just before other contributors come in, I would also like to invite our executive members who would also be supporting this agenda to kindly introduce themselves.
Hi, sorry about that. Good afternoon, everyone. I'm Councillor Fiona Venner. I'm the Executive Board Member for Children and Adult Social Care and Health Partnerships, and I chair the Health and Wellbeing Board. Thank you.
Good afternoon, everybody. I'm Councillor Salma Arif. I'm the Executive Member for Public Health and Active Lifestyles.
Thank you both for joining us. Back to you. Thank you.
Thank you, Chair. I'll move on to cover the section of the report around improving access to general practice. Both understanding and improving the experience of people accessing general practice is one of the key priorities for the ICB, and we discharge that via a primary care board. I just wanted to share some headlines with you this afternoon in terms of things that are included in the report that I think are worth drawing to your attention. So currently, based on our most recent data, we can count that we have over 20,000 core general practice appointments per day across the 92 practices in our city. So significant activity. 43% of those are booked on the same day. 71% of those appointments take place face to face, and around 50% of that total appointment is with a GP. Alongside those appointments offered within core general practice, we have a further 20,000 appointments per month delivered through the enhanced access service, which is offered at evenings and weekends, and a further 3,000 appointments per month via the same day response service, which provides an opportunity for practices to offer patients appointments when they themselves might have reached capacity in the practice, and also providers like 111 can book directly into those appointments as well. So within the report, you'll see some benchmarking data, because we are trying ever increasingly to understand access and people's experience of access, and also to benchmark across West Yorkshire in particular. We've got particular focus on growing the workforce. So as part of the GP contract over the last 4 years, there's been a scheme called the Additional Roles Reimbursement Scheme, whereby there's a menu of clinical and non-clinical roles that practices can employ and receive the reimbursement of cost for. So by the end of next year, which is the 5th and final year of the scheme, we will have had the opportunity to employ over 500 more whole-time equivalents within general practice, bringing a range of roles like pharmacists, care coordinators, social prescribers, mental health workers, just as some examples. One of the things that's really important to us is our work with Health Watch, where we listen very carefully to the insight gained from Health Watch and other partners in the city. So as I say, we're getting an increase in understanding of people's experience of access. And we chose to focus this year an optional module within the National Quality and Outcomes Framework. We chose to focus that quality improvement module on access, and so we co-designed that piece of work with Health Watch, and it includes things excuse me includes where we are in terms of use of the accessible information standard as an example. Since the production of the report for committee today, we've had publication of the new GP contract for the coming year, and there are two things within that contract that I would like to draw your attention to. It will be a requirement for the new contract next year for patients to be offered an assessment of need or signposted to an appropriate service at first contact with the practice. There is further requirement to expand the online access to GP records, and there'll also be a mandated requirement for practices to introduce cloud-based telephone systems, which will include functionality for call queuing and callback. That's the only detail I have of that at this moment in terms of what's been published within the new contract, but we are expecting at the end of this month a nationally produced general practice access recovery plan, which I'm sure will have more details in terms of those items. And then the only other thing I wanted to draw your attention to from the report is from July, the West Yorkshire ICB will take responsibility for the co-commissioning of pharmacy, optometry and dental services. That passes to the ICB as say from July. So we'll be working through the implications of what that means in terms of what happens at West Yorkshire versus what are the opportunities for us to work on those services at place.
Thank you very much. Any other contributors from that agenda item? Okay, board members, over to you now for any questions. Yes, Councillor Tyler.
Sorry, I haven't read the report, but and yeah, I can't remember now what I was going to ask. Sorry. Yeah, deploying funding to the community. You said you deployed funding with third sectors. I've crossed that off because I was going to ask you if you work with the third sector. In my ward, LS7 is a very deprived ward. I'm not speaking only for my ward, I'm speaking across the city. But I'm just asking you, which third sector did you consulted in LS7 and work with during your time? I'll come back to Jane after you answer.
So just to frame it, I think about 70% of that 3.1 million that was used for health inequalities went to third sector organisations in Leeds. So it was a really significant proportion of that health funding went to the third sector. That's largely because of a belief within the Health and Care Partnership that it is working in partnership with the community and with our third sector organisations is how we really tackle health inequalities rather than layering on additional health services. I don't have the full list of organisations. I might be able to find it while we're talking, or I'll certainly be able to follow up with you afterwards around those your particular ward in that particular area. I forgot what I was going to add to that. Who did we work? How did we work? So we worked through a number of different forums that we have in the city. So one is we work really closely with Forum Central as a coordinating organisation who help us engage with the wider third sector across Leeds. They helped ensure that we were to get messages out, that we had a process that was straightforward so that people could apply for the funding in a hopefully non-typical NHS way. So we made it a pretty straightforward process, or we aimed to, and the evaluation has helped kind of feedback about what we could do differently next time around process as well. And then we met some communities of interest groups as well. So there's a forum for that in the city that works with health partners. And lastly, we use the local care partnerships and particularly focused around those areas of highest deprivation, because that's where we wanted to target the funding. So we worked with the local care partnerships team who have really strong relationships with the third sector in those patches as well. But I can get you a specific list of the organisation that we did.
Please,
work with later.
It would be great if you could inform councillors. I work closely with the board that we know that you are doing these things, that we can highlight it to the community, because I'm not saying you haven't, but I haven't seen any difference in my ward. I've just seen the third sectors doing what they normally do. So it would be nice for councillors to know that you are funding certain projects, then we can advertise it, let the community know that you are doing something across that. Back to the GP contract, I can't get my head around GP. I can't get my head because why are the waiting list to access a GP with an appointment? I know you just said they have face-to-face appointment. I know individual. This morning, I was on a meeting, I had to leave. This elderly lady was ringing their GP from last Thursday, she told me, and she couldn't get through. So we are talking about phone communications. Yes, it's okay for me and you, but what about the less able who can't access these things? We need to really look what we are doing. I quite like the integration, but some are missing out big time.
Yeah, thank you. We do know that there's very variable experience in terms of people being able to access general practice, and as each general practice is an independent organisation, often the systems and processes they use can be different. So one person's experience of how to get an appointment in their practice can be very different to somebody else. But the work that we've been doing through the quality improvement module is to get each practice to really understand what it feels like for their patients to book an appointment, what it feels like to be on the receiving end of, like say, trying to get through on the phone or using online systems. I think the changes that will be introduced this year with the new GP contract, where there will be, it's signalling an end to the ring at 8 o'clock, and if we've got no appointments left by the time you get through, ring again tomorrow. Because what the new contract will require practices to do is to provide an outcome at the first contact. So once somebody gets through to their practice, they're either their need is assessed at that point, or they can be signposted to an appropriate service. So they're getting that first time rather than that need to keep returning, if, like I say, if an appointment's been full that day. But one of the things that we've tried to do through commissioning the additional activity that we've done through the same day service is to almost give an overspill for practices, so that once they're filled, because once their appointments are filled for that day, and it is a finite capacity, there's only so many people that work in a practice that can only offer so much capacity of appointment. So what we've done is to commission a service that sits around the practices, so there is an overflow. So if somebody really does need to be seen that day, there is an opportunity for them to be seen that day. But I do absolutely accept people's experience and people's perception of repeatedly having to try to get an appointment.
And this question, and that's what I can't understand. What is GP have to catch up on since the pandemic? I understand when the pandemic is limited amount of patient in the surgery, but what have they got to catch up on that they can't just go back before 2019?
So some of the things that they're catching up on, if you like, are some of the long-term condition reviews, some of the annual health checks that were paused during the pandemic. So nationally, there was there was a mandate to pause some of that more routine proactive care. So like I say, things like an NHS health check, for example. So practices are returning to pick up some of that activity that was lost, whilst also balancing there's an increasing need and requirement for people wanting to be seen on the same day. So that's why I say we at the minute about 41% of appointments are booked on the same day, but there's then an ongoing requirement for more longer term booked appointments to do some of that more proactive planned care.
I think just to add as well, it's not what we're seeing across the health and care system really over the last couple of years is an overall increase in demand. So there's not a static position from 2019 to where we are now. So for a whole host of reasons, partly things like the impact of lockdowns on mental health, cost of living, there's increase in frailty. So it's actually the level of demand across the board has significantly increased above and beyond what you'd expect through proportional changes in population growth or anything else. So it's not just about a backlog, but actually about overall acuity and demand increases that the system are grappling with right now.
I've got a few members who would like to say something, but I'll bring in Councillor Venner before the members.
Jenny's just largely made the point I was going to make, actually, which is it's really positive to have you both here, especially because you're leading on the primary care work, Gaynor, because we've talked so much in the Health and Wellbeing Board about access to primary care. It's the issue that comes up the most for people using frontline services. It comes through in all the Health Watch work and all the direct contact we have with the citizens of Leeds. That and dentistry, they're definitely the two issues that get brought to me the most personally in my health related casework. And I think one of the things I found it difficult to grapple with myself was we were hearing a lot that people are struggling to access GPs, but also hearing that GPs have never worked harder, and thinking how can both these things be true? And actually, Jenny articulated very clearly, we've seen an absolutely massive increase in demand across the health system, and also the workforce is really, really tired. And in some of the messaging that's come from Health Watch or come through other consultation with people using services, I kind of wanted to be, I felt really protective about how that messaging is relayed back to primary care, because we know that GPs are facing verbal abuse, threats. My best friend's a GP, they've had, damage to their building, had to have police at surgeries because of death threats. I mean, some of what GPs are facing is extreme in terms of a perception out there that they're not working hard enough because people are not, struggling to access primary care. And I think we've talked about this as well in the Health and Wellbeing Board. I think it's really important that the comms around this are right, and that people know that there is a wealth of other resource, as Jenny and Gaynor have said, at GP surgeries, not only doctors, there are other people that you can see. It doesn't always have to be a GP. And also, I think it's really good to convey that actually GPs are doing more appointments now than they were doing pre-pandemic, because I do think there is a perception out there that GPs aren't doing as much as they were, and that they're not working hard enough. We've heard quite a lot, haven't we, about GPs coming out from a really long shift and having a note on their car about why don't you get to work, and just it's a really awful situation where everybody's struggling, both the people that want to access GPs and staff working in GP practices. And it's the frontline least paid staff that are taking the flak of this. It's the GP receptionists that have to deal with, I think, the most of the frustration that patients are experiencing. So I think the communications around it is really important about what people can access through primary care as well as GPs, and also conveying that actually they are working really hard. And as Jenny said, in a context of increased demand and increased pressure that everybody's under. Thank you.
Do understand, Councillor Finney, I do need pressure doctors, and because I think I'll say doctors are taken away from doctors and being like managers as well. So they've got all those tools to work with. It's really hard for doctors. I 100% agree. But also we have to think of us as a patient that want to see our doctors, but I just think central government need to look again the pressure what they are putting to doctors with managers work and finance and things like that. That's where it need to look from central government to think doctors are human and doctors do get ill as well. I do understand. Thank you.
Okay. Yes, Jenny. Gaynor, sorry.
Yeah, thank you. I just picking up on Councillor Fenner's point. I think the communication and what patients can expect from a practice, I think, is really key. There was changes introduced during the pandemic, which I think were introduced as a result of the pandemic, and more quickly than we've had time to really take people with us. So the use of digital tools that are not right for everybody, but can be very useful to lots of people in the population. And also that this notion of that expanded workforce in a practice. I think we were in the early days of introducing those additional roles and being really clear about the added value that they could bring. And then I think obviously we've been in the pandemic and then post-pandemic. So that conversation, I think, with the public around some of those expectations hasn't been there. I think the point made around finances, I think my GP colleagues in the city would say probably a couple of things in relation to that. They are unhappy with the settlement in the next year's GP contract, and obviously, like lots of people in the public sector, are thinking about what action they might wish to take in relation to that. And General practices are whilst they deliver NHS services, are in effect small businesses. So all of the cost of living crisis that we know that is affecting, third sector on small businesses is there from a GP practice perspective as well, in terms of, cost of, utilities increasing, and again, needing to pay their staff the kind of, relevant salary levels.
Okay. Thank you very much. I will come back to you in terms of GPs. I've got one question, but I'll take, I've got Dr. Bill, Councillor Burke, was it yourself? And then I've got Councillor Harrington. So we'll take the three and then you respond if that's all right. Thank you.
Thank you, Chair. Two points, if I may. One is a question and then I'll come on to the other point. I'd like to dig a little bit deeper at the bar charts on page 28. And in particular, the one on the right-hand side of the page. And it tells us above, similar rate per 1,000 patients of GP appointments, and that's fine. At least 4 of them are very similar. Kirklees is a bit lower, but okay. But significantly lower rate per 1,000 patients for other practice staff. There are a number of possible reasons why that might be so. One would be that the healthcare needs of the Leeds population is less than the rest of West Yorkshire. I doubt it, but that might be the reason. A second possible reason might be that the GPs themselves are doing all that's necessary and they're not passing on to other practice staff. So they're just seeing a GP, whereas it may be in the other 4 areas that they're seeing the GP who's then referring it on to another member of the practice. That is possibly a good thing, not necessarily if they're just prescribing drugs, for instance, rather than doing other things. Or if you add the two together, Leeds is considerably less of per rate per 1,000 who see either a doctor or another clinician in the practice. Which one is it and why? And the second brief question is, we've heard mention of social prescribing, and it's mentioned in the document as well. Chair, might I suggest, I know this is the last board of this council year, but on the possible agenda for the next scrutiny board, that there might be a sort of deeper dive into social prescribing. Exactly what is it? How many practices do it? What do they do? What staff have they got to do it? And what is the evidence that it is the right thing to be doing? Thank you.
Thank you, Chair. Just say I completely agree with Dr. Beale around social prescribing. But the question, there's 2 of them that I wanted to ask, is about the home first model of intermediate care. It sounds fantastic, doesn't it? And I'm sure everybody would want that. But my experience of the reality is there's real implications with that. So people are delayed finding care packages that are suitable, particularly for complex needs. So if you've got a complex care package, quite often there isn't the resource there. So what steps, because I completely agree with all your objectives, but what steps are you taking to make that a reality is the first one. And the other one is reading through this. I mean, it's a great document, isn't it? But so is the health and well-being strategy. And there's lots of synergy and overlap between the two. At one point, you do recognise in your document that you can't deliver it all. So my second question is, how are you working closely, I don't mean on an individual basis, but I mean to align objectives and delivery models to make sure things are not duplicated and it's maximised, outcomes are maximised. Thank you.
Thank you, Chair. My question's about the PPGs. Elsewhere, we've said that there's 92 practices in Leeds. I'd like to know how many have actually got PPGs up and running, because I know that in my particular practice, we haven't had a PPG meeting since before COVID. So I'm sure that we can't be the only practice. So I would actually really like to know how many practices are operating PPGs and how many have been having meetings, and how is there any prescription about how often PPGs should meet? Thank you.
Thank you, members. Jenny and Gaynor, over to you.
So I'll go first on the intermediate care and the planning piece. So you're absolutely right. The reason this is the biggest priority and probably going to be one of the biggest transformational programs that Leeds has done and will do for a time is because we know that at the moment we haven't got it right, and that people spend too long in the wrong setting. And that isn't just about system flow and cost, that has real impact on people. And we know that people who spend longer in a bed than they need to spend, particularly a hospital bed, are much more likely to decondition, take longer to recover, and then require longer and more expensive care packages for the long term as well. So part of the intermediate care programme, one of the things to note is that it is a joint programme of work between health and social care. So the whole redesign includes the impact and knock-on effect, and how we look at social care packages and those complex packages in a different way as well, and working really closely with Caroline Barrier around this programme of work and the team. We've structured the programme to have a number of programs of work to do the redesign, to really do that, but recognizing that they all interlink as well. So there's as I said, there's a work stream which is around getting the transfer of care model right. So how decisions are made, that's not just the bit that happens in hospital, that's transfer of care across the whole system. There's a piece of work around what our neighbourhood offer is. So how does reablement need to look different in the future? What's the future of the skills and reablement services? And actually we've been starting to test out some of those principles, redesign principles, and I've been really impressed that all partners in Leeds are ready to be pretty bold with their model of care redesign. So we're not talking about another 3-month tweak around the edges of services to try and get them a bit more efficient, but actually fundamentally we've got different when you look at the map of current services, it's pretty complex. There's layers upon layers upon layers upon layers, and actually it's a real appetite to strip that back and start again. And that's not just from management, that's from the staff and the teams themselves. So our diagnostic involved lots of feedback from the staff working in the services who said we can do this different and we can do this better. So there's real ambition around that. And likewise with the community care bed redesign as well. So the programme of work will look to address all of that. The evaluation and the kind of economic benefit analysis has included a set of benefits around that we'll monitor around a whole range of things, from bed days in hospital to bed days in community care to our spend on home care packages as well. So we're not just looking at the NHS impact of the change, but actually how that translates across health and social care. So yeah, I completely agree that at the moment it doesn't work as well as we should, but really actually super excited about this piece of work. Like, we've got real buy-in across the system, we've got proper resource and a team to do it, and a real plan to do it as well. And then on that broader planning point, I guess in reference to the Healthy Leeds plan, part of the refresh of this plan is to be much more specific about the NHS bit, so we can be clear and not look to duplicate and not kind of all be at the same bits and not working in a really joined up way. One of the bits of infrastructure that we've got to help deliver the Healthy Leeds plan is our kind of programme board structure across the city, which are, you might have heard them referred to in the past as population and care delivery boards, and they're effectively groups of system partners that come together in a very strategic place to look at how they improve care for different populations. So that might be children, young people, people living with frailty, the end of life population, and that has all of the Leeds Health and Care partners are represented in that forum. And their role is to effectively improve the outcomes, drive better value and improve experience. And that's a relatively new infrastructure. So it's been running for about the last 12 to 18 months. A lot of that first task was often meeting people from the other organisations and like, oh, you've got a children's plan, well, we've got a children's plan, and they've got a children's plan. How do we actually create a single one? So that architecture, I think, is super important, because it's not just about what we put in a plan refresh, is it? It's about how we work together to deliver on that plan refresh.
Tony.
Yeah, thanks. Yeah. Just on, and again, just building on Jenny's point and Councillor Burke's point, I think is absolutely instrumental in terms of how we deliver a coordinated plan for Leeds. And there's all the obvious things I think that we've got in place that I guess you'd all expect, such as the teams being well integrated, such as the staff sharing ideas, sitting around the same tables and all that. And I think that's again what people would expect. But I think the proof is in what we do and how we change things on the ground and in neighbourhoods. So using primary care as probably the best example. One of the things that we've done under the auspices of the Health and Wellbeing Board is have a look at key areas that try and take pressure off primary care, so people don't go to see the doctor, you know, for one or two health related reasons. There's work issues, there's family issues, there's education, as we know. So a number of years ago, we sort of treading quite gently, we put housing support into some local care partnerships. We've also got some pilots in place around employment support, which is really, really key, because, you know, you'll all have seen in the news about the challenges of over 50s leaving the workforce. Those people tend to go to their GP quite regularly. So if there's some support placed in primary care, there's a good chance of getting them back into work and taking some of that pressure off practice staff as well. So rest assured, we are working these strategies really well, but there's lots more to do. And I guess some of the things I'll outline in the next conversation, we'll go through a few more examples on that as well.
Thank you. I haven't heard a response on Dr. Bill's question on social prescribing, and Councillor Harrington's as well on PPG.
Yeah, am I okay to pick those up now? Thank you. So yeah, just coming to Dr. Beale, just in terms of the first questions, Dr. Beale, around the graphs. So this GP access data has been fairly newly published national data. It only started coming out towards the end of last year. So it's given us a lot more information than we've had, and has given us the opportunity to benchmark. So you're right to pick up that variation. So we're doing a number of things really in terms of this, is looking at this data to make sure that the quality of it's right, that we're not missing anything, or we're not double counting anything, or that we have got our practices recording in the right way, and we're collecting that data in order to report on it. I think you're right to suggest a couple of hypotheses in terms of, well, is it that our GPs are doing more, or is it that, like I said, the counter to that? We know, like I said, overall, we've got that sort of about 500 appointments per 1,000 patients being offered, but we do have significant variation in that as well, just within Leeds. And again, part of the access work that we're doing is to really understand that, and really engage with practices in doing that work. Doing that work collectively. So I can't answer the question directly in terms of yes, it's this, or no, it's that. But rest assured, it is work that we are doing now that we have access to this particular data set. In terms of social prescribing, again, I don't have any figures in front of me now. I can provide information by way of a follow-up, but obviously I did note your request to have a deep dive. So at whatever point that's timetabled, obviously we can bring all of that data to the board. In terms of Councillor Harrington's question around PPGs. So all practices are contractually required to have a patient participation group. We know that not all are active, that some were stood down during COVID and have yet to stand back up. We had an event a couple of weeks ago where we had significant engagement from members of PPGs across the system, and one of the things that we agreed to do was to refresh our approach through the PPG network that the ICB supports and chairs, and to like I said, to do that audit really in terms of what's the position for each practice and what support do they need to get their PPGs established, and how might we offer a framework that says these are the things that you could and should be doing with your PPG, so we get some consistency and some sort of quality to that work.
Thank you very much. Okay, I do have but I think Councillor Thompson first, and then Councillor Anderson.
Thank you, Chair. I'll try and be quick. Just two brief questions. What happens when I may have misunderstood, when the 5-year reimbursement programme comes to an end? Is it a cliff edge? What's the expectation? And the same day provision is great, but it's a very long way for some people. If you're out in the northwest, it's a long way to Bermontoft, especially for older folk. And that's what I've heard has been offered. There may be other places as well, but it'd be helpful to understand. Thank you.
So the additional roles reimbursement scheme, like I say, it was offered for 5 years, but what we've got at the end of the 5 years is the guaranteed level of income. So it isn't a cliff edge. So we're fortunate in that sense. But one of the challenges and one of the risks that we're trying to mitigate is that as we move into next year, which is the final year, we want to maximise recruitment as much as possible, because at the end of that year, those will be the roles that are funded. So we do face challenges in that sense, both in terms of the number of roles that are available and also those people being available to recruit into those roles. So yeah, it's a real ongoing piece of work where we're working to maximise that scheme, and then we'll keep that funding for those roles going forward. In relation to same day response, we've got kind of several layers of things happening, I think, in terms of practices offering access. So we've got the 92 practices offering their core access during the day. We've then got enhanced access, which operates through 22 different hubs on an evening and a weekend. And then we've got, over and above that, we've got the same day response, which is offering a smaller amount of overspill. It does offer virtual appointments where that's appropriate, but obviously we do have a reduced number then of hubs. So absolutely get the point that it's not always in the best place for everybody, but again, we have to make a judgment call of the art of the possible.
Thank you. Councillor Anderson.
Thank you, Chair. My question is about capacity and increasing capacity and access in terms of dealing with missed appointments. So what are we doing about missed appointments on my PPG, which we're lucky we are meeting still? We made some suggestions when I first joined, because there were over 300 missed appointments per month. We put in a load of suggestions and that's now reduced quite a bit. So is good practice on that sort of thing being shared around the GP community? And then are we doing things to encourage people to take up what I'd call prevention appointments, so like breast screening and smear tests and things like that, because obviously that can catch things very early, which, as we all know, is the best thing.
Yeah, thanks, Councillor Anderson. I think we're able to say, and this isn't just a feature for general practice. I think, as Jenny said earlier, we're seeing more demand in the healthcare system than we've got total capacity for. So we're ever trying to balance that the available capacity with people's demand for access. And I think we are seeing, despite, like I say, more and more appointment availability, we're still hearing people feeling very dissatisfied with that level of access. I think there's probably some tempering of that in the sense of we've got over, like I said, 20,000 appointments per day. So the numbers of people that are experiencing dissatisfaction, I don't mean to minimise that in any way, but if you take that in context of the total, we've got lots of people that are able to use the capacity that's there and access in a way that's successful for them. We are at the moment, unfortunately, seeing a slight increase in that in the do not attend rate, so those missed appointments. And again, we're doing a number of things around it. So we've heard, for example, through our work with the deaf community, that actually having non-speaking ways of being able to cancel appointments across the board is something that community have asked for. So we're always looking at ways that we can put things in place that make it easier for people to cancel appointment when they don't need it. But you're right in terms of that sharing best practice. So where we have got active PPGs that are making a difference in the work that they're doing, the refresh of that PPG network will be that ideal opportunity to share some of that work. And in terms of public facing comms, sometimes we're faced with what we're allowed to do or what we're guided to do from an NHS England perspective versus what can be sometimes a more media narrative. And again, it's difficult in terms of getting comms right at the right time, but certainly there are comms campaigns planned throughout the year in terms of trying to hit certain aspects that where we've got particular issues, and certainly things like, you know, regular updates around screening and the importance of that always feature in those annual set of campaigns.
Thank you very much, Gaynor. We're kind of at the end of the timing for this particular agenda, but one question I would like to ask: in the funding that has been received, that which you have said is helping with other recruitment of like nurses, healthcare assistants, social prescribers, what has been done particularly to get new GPs into the system, short term and long term?
So the particular funding stream that I referred to is something called the Additional Roles Reimbursement Scheme, and that's attached to the overall GP contract. And there are a list of roles within that can be employed using that funding. The role of a GP or a practice nurse doesn't feature in that list. The list is roles that can complement GPs and sort of general practice nursing in a way that brings additional capacity and additional expertise to a practice. But like I said, the national scheme doesn't allow through that scheme an employment of a GP or a general practice nurse. But there are other things that we do in order to to attract GPs and nurses into the workforce. Again, part of our ongoing commitment to supporting practices with their workforce. I mean, we've not seen as much of a problem from a general practice recruitment perspective as other areas, and since 2018, our ratio of GPs per 100,000 population has increased, where other areas in the country have actually decreased. We've managed to, like I say, make a slight increase, and we do support practices in terms of, you know, is it a partnership GP that they're looking for? Is it a salaried GP? Is it a GP that could have a role or a special interest, or, you know, work flexibly? So again, we look at all of those options with our practices.
Okay, thank you. I know Councillor Arif would like to come in, and then I've got one more question.
Thank you, Chair. Just really briefly going back to Councillor Anderson's point, I guess, to reassure her about preventative work. So Public Health have led partnership work in relation to the NHS health check. So I think we brought a report in a couple of scrutiny boards ago, and that work has now increased, and we've actually got better averages compared to core cities across the country. So just to reassure Councillor Anderson, that work is happening because it is really important in terms of preventative work. Thank you.
Thank you, Councillor Arif. I was sad to hear from Councillor Venner about the treatment some GPs are having, and that is really sad to know, because if GPs are threatened, obviously, everyone wants to be safe in where they work. So why would they want to come to work if they're receiving abuse? And then it's the ripple effect. I mean, people are disgruntled. That's why they're abusing people, but nobody has the right to abuse anyone, let alone their doctors. So is there anything in place to safeguard our doctors and protect them from such abuse?
So again, we run regular campaigns in terms of zero tolerance, or the latest campaign was around leaving a gap. So, you know, if a member of the practice is subject to abuse, it causes them to leave. We're leaving a gap in provision of services. So again, like I said, those campaigns are running. There is provision within a practice if a patient is abusive. So there is a process by which that can be managed in terms of the ultimate sanction of a patient being removed from the registered list and being offered services via a safe haven type approach. But obviously, we would work with practices and the individuals to avoid that worst case scenario.
Okay, thank you very much for all that, for the report and for your contribution. And members, are we content with the response from all of them? Okay, thank you all so much for coming. We're happy for you to stay. We've still got teas and coffees, so feel free to do so if you would like to go through the rest of the agenda for us. Okay, so moving on swiftly is agenda item number 8, and that's Leeds Health and Wellbeing Strategy. I will ask think the only new person joining us on that agenda is Wasim. Okay, so since 2012, it has been a statutory requirement to have a health and well-being strategy. And with the current strategy in the process of being refreshed, this scrutiny board was given the opportunity last October to share its initial views around the proposed approach and refreshed priorities. So our board is now being presented with a further update report on the work undertaken since October to develop this strategy, and that includes a copy of the current working draft strategy document, which has been shared to each and every one of us. So I will now ask Wasim to introduce himself. Good to see you again, Wasim. Introduce yourself.
Thanks, Chair. Wasim Feroz, Health Partnerships Manager.
Okay, I will now ask Councillor Venner if you'll need to make any introductory comments.
Yeah, thank you. So the Health and Wellbeing Strategy is the document which guides all our work across the health and care system. And it's, in terms of the governance, it's overseen by the Health and Wellbeing Board, which is a cross-party board, I apologise, cross-council, so I'm in political mode, cross-council board, so it's different departments attend from across the council, but also we have lots of different partners who attend as well, including from the third sector and communities. And the Health and Wellbeing Board has a role to uphold the vision that's in the Health and Wellbeing Strategy, particularly around improving the health of the poorest and fastest and reducing health inequalities. And it also has a role around overseeing implementation as well. In a way, it's quite a challenging strategy to write in the current context, because we're trying to balance a few things. So we want, obviously, the plan to be aspirational, and we want it to continue to uphold our ambitions about reducing health inequalities. But it also needs to be rooted in the very stark realities of people's lives as we come out of the pandemic, with the cost of living crisis. And with the fact that, you know, the discussions we've just been having, people are struggling to get a doctor or a dentist. And therefore, you know, you don't want people to be looking at this plan and thinking, well, this is all very well, but I can't even, you know, get to the dentist. So it's really wanting to write a plan that reflects that, but also is still ambitious for the people of Leeds. And it also needs to recognise that a lot of the challenges that we're facing are very long-standing. So things like increasing life expectancy, it's not going to happen in the life of this plan. You know, that's the work of generations. So although that's obviously an aspiration, we have to be realistic about what can actually be achieved in the lifespan of this plan. And we have a team leads approach within the health and care system, which obviously came to the fore very prominently during the pandemic, particularly in the work that we did across Leeds with the rollout of the vaccines. And it also needs to continue going forward in the challenges that we currently face. I feel like I've talked about the health and wellbeing strategy so often that I said to my research today, I couldn't remember who I was speaking to at a meeting I'm going to on Friday, because I feel as I've been to so many different meetings and so many different audiences to talk about this. But I sometimes think, who is it I'm talking to today? But that's really positive, because obviously that means we're going out to loads and loads of different groups. So I was at the Safer Leeds executive yesterday, talking about the crossover with their working communities. And we've got the meeting that I couldn't remember what I was doing on Friday is actually a really big meeting of the LCPs who are all coming together to talk about the health and wellbeing strategy. I think there's about 80 people attending that meeting. So we are doing loads and loads of consultation with stakeholders, including, of course, with people themselves who are in receipt of health and care services. And I think we've been here before with this strategy, haven't we? I don't think this is our first visit. So also we want to get your input as we continue to develop it. So thank you, Chair.
Thank you very much, Councillor Venner. Yeah, and I do hope you all have had time to read that strategy, very comprehensive. So Wasim, it will now be up to you to talk us through that report. Over to you.
So hopefully members have had a chance to read the working draft. Just to emphasise, there is an early working draft, so this is part of the engagement to help ensure we're strengthening the narrative and ensuring we are focusing on the priorities that citizens, but also you as elected members feel are important as well. I think one of the things I just want to highlight, Tony might want to add some more points, is just reflecting on the last conversation we had at Scrutiny Board and how we've responded to that. So one of the key points that really came through, I think, was the importance of reflecting the priorities of carers within the strategy itself. So that's one of the things I hope you see in the early working draft, that we've tried to reflect and actually identified more explicitly in one of the 12 proposed refresh priorities, that support for carers and enabling people to maintain independent lives. But just to add to that, we're not going to, the approach we've taken is not singling out just one priority to focus on particular groups. I hope you see across the strategy, we've really highlighted those priorities across the 12 refresh priorities around carers and how that impacts those. And we want to reflect that within other groups as well. And one of the other things I think I wanted to highlight was the importance of that equality, diversity, inclusion lens on this, and that's really reflecting on the West Yorkshire Partnership Strategy and the Healthy Leeds Plan, and recognising the different needs of different communities, and that approach that's reflected across this. And I hope you can see in the early working draft, we've tried to embed that thread across the strategy narrative and in the priorities that we've reflected. And then just a final one before I bring Tony in, is around the two-phased approach. So phase one is what we're in now up until July, where we will launch the strategy alongside the inclusive growth strategy refresh, which we're working closely with colleagues on that too, to make sure they're aligned too. But also there's phase two, where we've made that commitment under each of the 12 refresh priorities that will have clear action plans. Some of those already existence, like the mental health strategy that was recently agreed, but others in particular areas that we want to focus on around housing, employment, inequality and research is some of those areas that we think we can make a difference and get into the detail of those plans post-July once the strategy is launched. So I'll leave it there, Chair.
Thank you very much, Wasim. Okay. Board members. Oh, Tony. All right, come through.
Yeah, thanks, Chair. And just in addition, I think most of the points have been made, and hopefully you've read the paper. The engagement that we've had, and like Councillor Venner mentioned, sometimes you don't know if you're coming and going. We've literally probably been to 20 to 30. I can't remember the exact number actually, but a lot of different groups and conversations, and each one of those has added to the richness of the strategy. So a key one, I think, is that at the last scrutiny, as Wasim said, carers came out really strongly. Carers wasn't reflected in the previous health and wellbeing strategy, so we've now got that as a key issue in there as well. I think likewise, some of the challenges, particularly around things like employment and housing, we have flagged them up in the past, but they've been very aspirational. I think this time round, we're really key to put some meat behind those priorities. So, for example, we've got the Breakthrough Project for housing and health, which has got a number of priorities in there around improving support, for example, to people in tower blocks with mental health or other issues, looking at the selective licensing programme and how we can develop that. And then likewise on employment, we know the challenge in Leeds at the moment isn't really around the number of jobs that are available. It's the huge inequality in the jobs market, and particularly with people with learning disabilities or mental health. Refugees and asylum seekers are simply not getting the access to employment and job opportunities that other communities are getting. So we're thinking through how best to develop that. And linked to that is that piece of work around looking at the over 50s as well and putting some employment advice into primary care. So there are a couple of pilot projects that my team and City Development have got in place. And that's absolutely something that we're looking to build over the next period. And then I guess finally, in terms of some of the things that look a little bit different from the previous strategy, the work around research and the universities, again, has probably in the past been a little bit ivory tower and sort of sat in splendid isolation. But the conversations that we've been having this time have been ensuring that our university colleagues and all our academic colleagues actually are putting their gargantuan brains towards helping us solve some of the problems of the city, particularly around inequality. So how we develop things like the Leeds Academic Health Partnership will come into the strategy as well. And then finally, just reflecting Councillor Venner's point, you don't change things like life expectancy overnight. And we do know things particularly on healthy life expectancy in deprived areas have gone into reverse. So we are setting a longer term plan behind this strategy. It will run to 2030. Obviously, most strategies tend to be the standard 3 to 5 years. And we're particularly building the alignment with our colleagues in inclusive growth, and all the work in and around climate on the one hand, and then on the other hand, all the more operational work that you've heard from our NHS colleagues as well.
Thank you very much. In the strategy and looking at, I remember 2 years ago when you delivered the Mammoth City approach. I really, really like that. That is one bit that I would like to know in terms of update, where how effective has that been so far from when you started?
Thank you. So the Marmot City approach, the commitment's been developed over the last year, but in terms of what the Marmot City approach actually is, we're just in the process of starting that now. So we have a paper which will be coming to the April Executive Board, for example, which will be giving the update on that progress, and recently reported on progress at the Health and Wellbeing Board. But we're just starting in April working with the National Marmot team, so the Institute of Health Equity, Michael Marmot's team, and commencing a 2-year programme of work in partnership with them to really progress and move that work forward. So work has begun and been taking place in the build up to that around the initial priorities, particularly around Best Start and around housing, and aligning with some of the other housing work that's been done. But the real focus of the work is about to get going now, once we start working with the Institute of Health Equity and those national teams working in partnership, developing that, and we'll keep this committee as well as others updated with the progress as we go on that. So yeah, really exciting time, and just commencing that, and there will be a wider launch event that we're just planning at the moment for that, which will be happening in mid-June, where there'll be obviously politically led, but there'll be an opportunity where Professor Sir Michael Marmot himself will be in Leeds talking and really setting that out as well. But I don't know if there's anything you want to add. Thanks, Chair.
Thank you very much. Exec members, did you want to say something? All right, okay. Well, thank you very much, Tim. The way you jumped to answer that question, that shows that is definitely
I know, I was
the radar. So
I'm deputising for another colleague. I was just about to give them an advance warning to check out I wasn't there, and I heard them aren't ready, so I thought I was probably going to be okay. The only bit I'd just also add to that, Chair, is this is absolutely one of the absolute principles that we've taken to all the Marmot work, is that strategic alignment with the Best City ambition, with the Healthy Leeds plan, but with the 3 pillars. So this is absolutely being developed completely in line, adding value, but very much in line with the inclusive growth strategy, but also very much with the health and wellbeing strategy. So they're very, very well integrated in terms of their development. Thanks.
Thank you very much. I can feel your enthusiasm on that one. So that's great. Well done. Okay, Councillor Thompson.
Thank you, Chair. 2 brief things. Really welcome the specific mention of learning disability, neurodiversity, and especially on World Down Syndrome Day. It feels particularly appropriate to recognise that. Maternity services are covered in fairly vague terms. Very aware that postnatal care can often be the Cinderella aspect of maternity care. So from my perspective, it'd be good to see something more specific on that. Thank you.
Yeah, that's a strong point. We have got Best Start as a key organising principle within the strategy, and it is rooted in the life course approach. But we can bring that out more clearly. Yeah, maternity care is absolutely central, isn't it? You know, to how we manage, I guess, sort of children's forward, I guess, their lives. So yeah, key points, and we'll add that in as well. Thanks.
Thank you very much. This question is actually for board members. Obviously, with different health practitioners going into different wards and helping meet the health of the poorest, because obviously the ambition and the priority is to meet the health of the poorest the fastest. Any one of you felt it? Have you felt them in your wards coming in and dealing with issues? Blood pressures, diabetes checks, because I saw that in the report in terms of health practitioners going around the city. So anyone felt it?
Not in terms of specifics like that, Chair, but certainly in terms of work directly with public health around green spaces and development, which obviously overlaps and spins off. So we work quite closely on that agenda, but none of the others.
Okay, Councillor Taylor.
That's why I've asked the question earlier, Chair. Who do they contact in the ward? Because I'm a champion in my committee, and I don't know if this works. It might be happening, but I don't know of it, and it would be nice to know.
Well, I know it's happening in mine. I just wanted to know if it's happening in others. Every Friday between 12 and 2, we've got health practitioners who are taking blood pressure from people, giving them advice on diet, giving them about advice on diabetes, the very common diseases, especially with people from ethnic minorities. And they are health practitioners who are in that same community. And I see such a very long queue, especially of women, every single Friday with this health practitioner. So I'm just hoping that that's the same in other wards. That's why I'm checking. Yes, Councillor Taylor.
Ask you the question, where does it happen in LS7, my ward, Chapel Allerton ward? Who does it in Chapel Allerton ward?
So I can sort of answer some of that and more generally as well. So many of the programmes that are targeted inevitably in the areas where there's greatest demand. So a classic example is the lung cancer screening in Seacroft, which has had a massive impact. In LS7, Chapeltown, Chapel Allerton, the Regional Centre has a number of really excellent targeted programmes, everything from obviously from employment support to support with cost of living. There's a clothes bank in there. And then I guess more generally, it is all that targeted work that's either done in GP practices via things like the NHS health check, which is obviously scaled up to impact in particular areas. But it is an area, there's no question we need to do far more on this because the level of demand is huge. We've got some brilliant third sector services. So Inkwell and loads of the organisations, you can tell I used to live nearby there actually, so I do know it quite well. There's lots of really great services that orbit particular areas who haven't always been brought into the conversation, I think, and that's something I think increasingly we need to do via the third sector work. So we've got a conversation with the third sector partnership in a couple of weeks about how we might do that as well.
You just mentioned in the regional centre, yes, it does happen, but nothing compared to what Councillor Marshall said, which is public health. I want to know, where is that happening? I know we've got BHI. Are you working with BHI? Are you working with Feel Good Factor? I don't know. I'm the L champion, and I would like to know because I do visit my elderly ladies. I love my elderly ladies. I push to go and get these things done. So please keep me informed.
Hi, Chair. Yeah, I mean, fair question. I can certainly take it back. I don't have the details to hand of all of them, but there is a range of programmes that we're involved in and that we commission around a number of these. So some of those are around blood pressure, some of those are around other things, working with voluntary sector organisations. And we've just awarded some more money working in partnership with Active Leeds, in fact, around doing some of that around looking at case finding around high blood pressure and things. So I can go back with colleagues and get some details about some of the activity that's happening, particularly in LS7, and get back to you if that's okay, Councillor.
Please, I believe in communication and team working, because it's not for you to do or for me to do, it's for us to do. Absolutely. So that's what I believe in.
Yeah, that's great.
Thank you very much, Tim. I think it will be very helpful if all of these activities are shared, especially with elected members. They are closest to the, to the grassroots and to people and to communities, third sector. So the work is being done, but if people do not know, then obviously that's where the whole issue about access. But obviously, if members are aware, then they can also help signpost so that people within the community know that these things are happening, so that together we could tackle all of these health inequalities. So thank you before that. Yes, back to you, Tim.
And just to say, in response to that, I'm happy to take back the general comment back across public health colleagues in the team to really stress that point about the activity and about using elected members, but using the health champions through the committees, the community committees, as a way of ensuring that people are aware of what's happening in those particular areas. But yeah, absolutely, I'll reiterate that and mention that to colleagues.
Thank you. Okay, any other questions or comments on this? Yes, Tony.
Yeah, just a really quick addition. You know, we saw in things like the vaccine program actually that if we do a top-down approach, it doesn't work. So we've got to work with all communities, yours and everyone else's, and actually the work with via the community committees, with the health champions, with organisations like Black Health Initiative, and actually all the other third sector organisations, not just ones that work in the health sector, ones that work in housing, ones that work in employment support, is absolutely central. And this strategy is rooted in that bottom-up approach. And not wishing necessarily to speak for Councillor Venner here, but one of the things that she's done a brilliant job of in the Health and Wellbeing Board is bringing in that community and patient voice to conversations, which we probably not always had in the past. So things like the People's Voices, the allyship programme, which has been really successful as well, has made a real difference in hearing from a really diverse range of Leeds residents.
Thank you very much. Councillor Venner's good like that. So yeah, well done, Councillor Venner. Yes, Councillor Taylor and then Councillor Burke.
Mind you, when I says L champion, I'm not just L champion for my ward, I'm L champion for Motown and around there as well. So it'd be great to know where it's happening. I can visit and make sure it's going, yeah?
Yes, Councillor Arif.
Yeah, just to respond back to Councillor Taylor's point, we do have health champion meetings on a quarterly basis. I think we had one, if I'm not mistaken, a couple of weeks ago. So yeah, absolutely. So what I can do just to alleviate some of your concerns is make sure that communication in terms of what is specifically happening in your community area, to do some of that work. But just to also say, going back to the NHS health checks, one of the things we looked at was access, perhaps looking at weekends and looking at, because sometimes people are working Monday to Friday, 9 to 5, can we do some evening clinics? I think going back to what Tony's point was about the learning from COVID and actually how successful we were when we went to the community and when we didn't expect the community to come to us, because sometimes there are barriers, and some of those could be financial barriers of getting 2 buses to get to specific areas. So I think that work is ongoing and something that we're trying to embed as we go forward. But yeah, absolutely. But in terms of the communication, Councillor, I'll make sure that gets fed back. Yeah, I do. Thank you.
Thank you very much, Councillor Taylor. You're free to come and visit Little London and Woodhouse every Friday, and we'll also take your blood pressure as well. Okay, then don't complain. Right, okay, thank you all very much. We'll wrap up for that. Councillor Burke, sorry. Okay, over to you.
Thanks, Chair. I think the report's fabulous, and I think lots of the strands, but one in particular jumps out at me, and it's the jobs and economy, because I think lots of strands in that particular element overlap lots of other things. So it links into, I won't list them all, I'm sure you already know. So I'm interested when the action plan to deliver that will be available so that we can have a look and read. The question is, are we doing anything within communities? And I know the work that the council already does around skills and jobs, but it needs to be enhanced more, doesn't it? And there's my second question, which is very quick. This is great, but what about targeted approaches? So, for instance, Sturton and Hunslet, lowest life expectancy in the country. It seems to me that we need to perhaps target areas like that, which is in my community committee area, and I'm sure there are pockets of other things, and that certainly fits in with my approach, doesn't it? That it's a whole city together going forward.
Yeah, I can certainly answer that one. The jobs and economy one is going to become ever more important, I think. it's worth pointing out the evidence is actually quite clear around what works, and we've got some really, really strong pilot programs. So the one I mentioned in GP practice, for example, has been really successful. We ran an 18 to 25s version of that got a number of children, young people back into education or into work. And then when you take it from the other direction and look at the pipeline into jobs, the real key, and this was quite controversial when we did it, is to put the job and recruitment fairs actually in the heart of the community rather than put them in city centre. Great as the city centre is, you know, people aren't going to traipse all the way from Seacroft to the Leeds Arena for an NHS jobs fair. So the work that we did in Lincoln Green, which was a number of years ago now, as I'm sure you all know, was really, really successful in getting entry-level jobs into particularly into the hospital, but also into other NHS services. And we've rolled that out to Armley and a couple of other areas as well. And that's also been quite successful. But the big challenge with the employment and health programs is just a really, really simple one. If we had the resources to scale them up, we could make a huge impact because there's such a level of need, but there's also a lot of hidden talent out there. So particularly people maybe with low level anxiety and depression, learning disabilities, neurodiverse, that there are some groups that actually with tailored support, we could get into many of the jobs that are there. But at the moment, we don't have the resources to scale them up. But should they come, we know exactly what we need to do. On the life expectancy and the targeting, yeah, there's some absolutely shocking data. Hunslet is a classic example, isn't it, of women's life expectancy in particular going into reverse. So if we talk about proportionate and targeted approaches, clearly we need to be, you know, working first and foremost in some of those areas. But the priority, and you know, stealing Tim's thunder now, is proportionate universalism, which means all areas will get a service, but it will be proportionate to the level of need. So there are pockets of deprivation in some of the outer localities as well, as we know, and the challenges around things like transport and employment are city-wide. So we're trying to take a proportionate approach in how we commission and deliver services.
Thank you. It's just that this perhaps crazy idea bubbling around in my head around peer support, particularly around skills and employment. Now, I used to manage job centres and we used to regularly encourage people to help their peers. So I've kind of got this idea in my head that within communities with very little input, we could kind of run those regular surgeries, for want of a better term, and help people. So you can come in, you can speak to an advocate, you can speak to your health champion or whatever and get that help, yeah, that they need.
I was going to say, you can't reach a community as you'd like to. You are doing marvelous work in Leeds, but you're not selling yourself. Nobody knows you're doing the work. I know some of the work just by reading the papers. So I don't know if you watch Ghost when it says, use my body. Use us counsellors. That's what we're here for. We're here to promote what the council is doing, because the council are doing brilliant work, but outside don't know. So let us get together and show it outside. You've got 99 councillors, use us.
Short time. That's just basically what she's saying. Yeah. Okay, back to you, Tony.
Yeah, I'll just really quickly. Yeah, the communication of the strategy is absolutely key, no question, and getting those positive news stories out there. Councillor Taylor's absolutely right. Councillor Burke's point about mentoring is not a crazy idea. There is some of that's done already. It's a really effective way, particularly, in fact, for people in the late teens to be mentored into positive employment. And one of the challenges, we've probably not brought it out as clear in this strategy, but it's in some of the work that children's services and others are doing, is to do more targeted work in some of the inner city schools to make sure that children that are working well and succeeding at primary school don't drop off as they get older, which we know is a huge challenge, particularly for free school meal kids. So I think that probably is something we need to bring out a little bit more clearly, actually.
And there's a thing about cross-generational kind of involvement, isn't it? Which then perhaps will encourage the over 50s and reduce antisocial behaviour, hopefully, and you kind of start going across your strategies. I'll shut up.
Okay, thank you very much. That brings this agenda item to a close. Thank you very much, Wasim, and for all of you, Tony and team, for your contributions, and our exec members. So moving on to agenda item number 9, physical activity, which I like very well. I believe Steve Baker's joining us. Yep, thank you very much. All right, you all have 2 minutes break, only 2, and I will start right after 2 minutes. You've got 1 more minute. Okay, that's it now. Break over. Okay. Right, okay, so welcome back. It's agenda item number 9, physical activity ambition. So our scrutiny board recognizes that being physically active is essential for good physical and mental health well-being. We therefore gave a commitment to continue monitoring progress surrounding the physical activity ambition work. The update report within your agenda pack therefore reflects on the work that has been undertaken since our last update in February of 2022, as well as giving an update on the governance arrangements for this work and the proposed new city-wide physical activity vision. I will now ask Steve Baker to introduce himself and your team.
Good afternoon, Chair. I'm Stephen Baker. I'm the head of Active Leeds, and I'll introduce my colleagues to the left and the right as well. Katie Bowden, who's a development officer for Active Leeds, and Emma Powell, who kind of heads up this kind of physical activity work for our service. Thank you, Chair.
Thank you very much. Before I call call Councillor Arif, I would just like to let you know, Steve, last year we visited a few leisure centres and Airbra was one of them. And if you do remember, we kind of made remarks about the bushes and the grass and all of the mess. I was there on Saturday and I'm pleased to let you know it was nicely done. It was clean, it looked green and it looked very healthy. So I just want to say well done to yourself and to your team and keep it up, because I didn't tell you I was going there. So that shows that it's being done with or without the scrutiny board intervening. So keep up the good work. Councillor Arif, for any introductory comments, please.
Thank you, Chair, and that's good feedback to have. Mr. Shopping is always good. So this report provides an update on the development of the physical activity ambition for Leeds, which is being led by Active Leeds and Public Health together with partners from across the city. The latest data for Leeds shows that 31% of children and young people are inactive, 23% of all adults are inactive, and 36% of all older adults aged 65 and over are inactive. We also know that there are significant differences in levels of physical activity across the city, with inactivity levels in some poorer communities more than double those of more affluent communities, and unfortunately the gap is only widening. A new vision has been developed and informed by the Get Set Leeds conversation, the COVID-19 rapid reviews completed by Leeds Beckett University, insight from the Big Leeds Chat, council policies and strategies, and insight from national campaigns and similar projects. The revised vision for the physical activity is Leeds is a place where everyone moves more every day. This is supported and championed by the newly established Leeds Everyone Moving More leadership group, of which I'm a part of. The aim of the programmes of work is in line with the new proposed vision. It is to create a place where everyone moves more every day and where everyone has the opportunity to live and benefit from living a more active life. All partners recognise that the approach to decreasing inactivity levels is long-term, involving systemic change, as well as seeking to harness the strength of individuals and their communities. The report also provides progress on some key work streams in this area against the priorities that were set last time at the board. Thank you, Chair.
Thank you very much, Councillor Arif. I'll now call on Steve.
Thank you, Chair. Just to kind of, obviously everyone should have read the kind of report, so I won't go into detail in terms of that aspect and cover some of the bits that Councillor Arif has already gone through. But in terms of the vision side of things, last time we were here, we pretty much were in the process of just setting up the governance arrangements, which has taken some time in getting the right people on that kind of leadership group that we have kind of delved down to where and who is we feel is quite influential in terms of the sphere of work. So that governance arrangement has been up and running, and we've had a few meetings now to kind of start the ball rolling and moving this thing forward, really. It's probably fair to say that the group are all very excited about this piece of work and being involved in it and championing this kind of piece of work. So it's very exciting to be in those meetings. They're probably not their standard kind of meetings. We do get up and move a little bit as well. So it's very important from that side of things. But ultimately, in terms of the vision and where it came from, is obviously the word physical activity isn't in there. And that was pretty much done on a purpose, really, in terms of what people see and hear about and what they class as physical activity can be very much, whether that's going to the gym, going to a swim, it's very structured kind of activity that people kind of a connotation with that. And so on purposely, we've kind of removed that kind of word in there, and it is very much around just getting people moving in any shape or form, whether that's just walking to the shops, whether that's just taking the extra bus stop, the lights, just to kind of make it clear that people just want to get up and be active in some form. And that's very much around how we kind of see this the kind of visioning element of this and how we kind of speak to people. But it's very clear that obviously there's a lot of work that is happening in terms of changing our spaces to make them more accommodating from a physical activity point of view, where that's lots of work in the parks areas and the green spaces. But in terms of how we make those activated, those areas is really key from our side of things. But again, it's been clear that those spaces are available for people just to go for a walk, go for a cycle, go for a scoot with the children. So those kind of things are really important from our side of things. And it's trying to get that message across to people that it's so much more than just structured activity that we need people to get doing. Whether that's just, if you're home working, for example, just getting up and moving about and going for a cup of tea and on a regular basis, it's those kind of simple messages that we want to get across. And that's about how we work from a systems perspective in terms of making it clear from the care homes, for example, how they can engage with their kind of members and stuff as well. So that's really key from our side of things. Lots of work has happened and taken place, and obviously as part of the board last time, we looked at some priority areas around children and young people specifically, and also the kind of older age group, where again a lot of the reports kind of highlight some key kind of inactivity areas within that as well, and the health inequalities that kind of exist, especially around children and young people in terms of their mental health aspects as well. So there's a lot of work that is happening on that front, and engagement with lots of partners and stakeholders across the piece on that front. Similarly, around just getting people to play a little bit more and giving people the spaces and the lights as well is a huge area for us, which we're just going through an assessment on as well. And then lots of work in terms of co-producing a lot of activities and working with communities in our priority neighbourhoods to make sure that we don't go in there with a message, this is what you will do, or this is what we think you should be doing. It's very much about using the kind of communities themselves to dial up a lot of kind of initiatives. There's some in that report that kind of highlights some of those elements as well. And then fortunately, we have been successful in applying for some Department for Transport funding around social prescribing and how we use that to kind of engage with specific areas in terms of Birmingham Top, Hare Hills and Richmond Hill, around using cycling, walking, those kind of initiatives as part of that, which again, that kind of work has just started to move a little bit now. So hopefully over the next period, we'll be able to report back on that in a bit more detail as well. Thank you, Chair.
Excellent. Thank you very much for that, Steve. Members, any comments or questions? Yes, Dr. Beale.
Thank you, Chair, and thank you for the paper and the presentation. It's good to see the sort of work which is going on in Get Set, Leeds local, but not everyone wants to attend those sort of group or competitive exercise opportunities. Indeed, the timing may not fit them, or they may not be interested in that particular aspect. And you mentioned parks and green spaces. Critical that those parks and green spaces are safe, and are safe for children, and are safe for women, and are safe for all. So that's absolutely important. The question I want to ask, if you go down to some of the green spaces or small parks, like Lovell Park just down the road, or the one opposite the Northern School of Contemporary Ballet, or whatever it's called nowadays, they've got little exercise circuits with robust sort of gym equipment in. How many of those are across the whole of Leeds?
Thank you, Dr. Beale. I couldn't give you an exact number across the Leeds area, but that's certainly something I can take away and just come back to you in terms of where they all are, the localities of them. There are a number in a lot of parks areas, which our kind of parks and countryside team kind of deliver on. So yeah, I'll come back to you in terms of the exact numbers and exact locations of all the kind of areas of those green, the gym elements of that side of things. And they are an important part of how we kind of use it on an informal kind of basis and the likes. You know, we even look at it in terms of an additional offer to the gyms in our leisure centres and environments that people are outdoors, and it's like, just because they're outdoors outside the leisure centre doesn't mean that people aren't going to then come to the gym side of things. So they are an important part of that. But again, it's about how people feel capable of using that kind of equipment itself can still look quite scary in terms of all the mechanical and metal parts. So it's about how we kind of encourage people on that front to be able to kind of use that equipment as well.
Any supplementary question?
No, just to say that, you know, I think, I don't know how many there are, but they ought to be within reach of everyone who might want to use them. I mean, they're different from the gyms and they're free. So those people who can't afford to pay subscriptions to gyms or even go for individual sessions can just go down, and they can use them either by themselves or they can go around in a small group as it sort of compete with their spouses or their partners or their children or whatever.
Yes, definitely. And we do activate and make use of some of that equipment in the parks areas as well for us. Some of our kind of activation areas that we kind of deliver on some classes outside in the parks and stuff as well. So the teams kind of use those kind of elements where they are pretty much to kind of, make use of them in small groups and get people doing it. Even on a walk, for example, they'll include that as part of their kind of walk side of things as well. But yeah.
Thank you very much. And just for officers to note that whenever you tell us you're going to come back to us, the good thing with our scrutiny advisors and officers, you will come back because we will chase you. So we won't forget. OK, so please don't forget whatever you say you're going to come back to us with. It's been written down. So please do come back. Thank you very much. Councillor Harrington and then Councillor Burke.
Thank you, Chair. There's a couple of things. On paragraph 40 on page 75, the last sentence, there's also 6 age-friendly ambassadors recruited through Active Leeds. Be interesting to know where they are based, because I haven't heard anything at all about that in the outer northeast. And then the other issue is kind of aligned with the outer northeast area. There is one leisure centre in Wetherby, which is tiny. It's minuscule. It has a tiny baby pool and it has one adult pool. There has been some work done on energy efficiency, which is fabulous, and it's really energy efficient now. But the changing rooms haven't been updated and modernised for 30 years. People actively are not choosing to use Wetherby swimming pool because it is in such an awful state. They'll go to Tadcaster, which is a community run pool, and they keep saying, what are you doing about swimming? What are you doing about the leisure centre in Wetherby, which is absolutely awful. It's really, really bad. So it's not actually encouraging local residents to go there. Elderly people would go, some of them would really love to use the gym, but it's in the basement and it's dingy and they feel it's really difficult for them to access. There's no lift for them to get into it, etc. And for an accessibility situation, if you're in a wheelchair, you have to come up a big slope at the side and then come along the side of the swimming pool to actually access the facilities, which is patently unsafe. So we're all about encouraging people to get active, and I'm really, really keen to do that. And in our area, we have a very large demographic of over 60s of people who would really love to do that thing, and aqua aerobics and all those kind of things. But where is the investment going to come from to update outdated facilities? Thank you.
Thank you, Councillor Harrington. I believe there was an email that came from yourself on that, and I did pass that to yourself, but obviously you will come back on that, won't you? Okay, Councillor Burke, and then we'll get Steve to respond. Thank you.
Thanks, Chair. It's just a couple of things. Again, I think the report's very good. And you do mention within the report around parity between physical and mental health, but only in terms of young people. So I think that needs to be right across the board for all ages. I would echo what Dr. Beale said, but perhaps take that a little bit further. It's not just being in the park. In some areas, it's actually the travel to. So that links with the other strategies, doesn't it, around antisocial behaviour and so on and so forth. Disabilities, perhaps, and focus on perhaps people with low-level disabilities who don't think it's for them. So not all disability is visible, is it? So there's a whole group of people who perhaps would, with some encouragement, become engaged. It seems to be missing. I apologise if I've missed it when I read it. I don't think I have, but that's just another one. And there's another bit, and that's around some areas. And I know it's something that public health are working on quite, and that's around domestic violence, isn't it? So some people would definitely want to be engaged. So I guess what I'm saying is linking up and that synergy between the two, so that those people who are experiencing that can have the opportunity of going and having a bit of a safe hour while they're exercising or whatever. I don't have the answer to that. It's just a suggestion.
Yes, thanks to Councillor Blake. So in terms of the kind of mental health, you're definitely right. It's far reaching than just young children and young people. Obviously, in terms of our priorities, we kind of focused on the children and young people at this stage in terms of that kind of mental health side of things. But there's outside of that, there's this kind of universal kind of offer that we kind of need to get out and messaging around physical activity and the benefits to mental health. And there's a lot of research now coming out around that side of things to, you know, in terms of making sure that people aren't just using antidepressants as an example straight away, that physical activity actually can probably just do as much benefit to people by getting them a bit more and moving more on that front. So there's a lot of research coming out about that and how that can actually help the kind of, before they go into the medical kind of platforms, is actually we can actually prevent some of that through kind of physical activity. So you're definitely right in terms of the mental health, and it will be something that we'll kind of bring out a lot more on that front. In terms of the disability side, again, it's probably where our priorities have been at this stage is focused on those side of things. But again, it's not saying we've kind of don't do anything on that front. Again, for example, we just started doing some sensory kind of gym sessions and for people who have suffered from kind of autistic kind of side of things in terms of bright lights and those type of things, and we've started rolling that out across our gyms and different things as well. So yeah, just some of that low level sort of thing in terms of some of the disability side of things as well is really important that we kind of target. So again, there is a lot more in that sphere, and I can probably get a list of items that we kind of do in that front for you as well. And was there another point? Wetherby, sorry, sorry, I didn't forget about Wetherby. Wetherby, the building itself is limited. You're quite right. We're kind of looked at a number of different things to improve the access to that building. Unfortunately, the location of it is, and the age of the building itself is fundamentally flawed in terms of how we get to improve that kind of side of things, and are very similar within the inside the building as well is limited in terms of moving things around. You talk about the gym being down in the basement area, and that is from my side of things is not where I want it to be either. And believe me, all the leisure centres I would have as good as they can be in terms of the facilities and the likes. We are just developing the gym area at Wetherby, so we are spending some money to replace the kit equipment down in the gym area as well to enhance that offer a little bit. But like I say, we are quite limited in terms of what we can do in that space and working with the building we've got in that area as well. So we have tried to do as much kind of decoration and stuff as we possibly can, but it does require some fundamental kind of improvements, and those are the kind of things we try to look at. But like I said, in terms of the actual building itself is quite limited, and without building something totally new, it's hard to kind of make a huge impact on in terms of that. But the changing rooms, again, it is something that's in our kind of priority list of stuff that we try to do as much as we possibly can to enhance them. But again, because of the spaces they are and the lights, there are some limitations on that. But I can assure you we want to improve the facilities there on offer, and we'll do as much as we possibly can. Because you're right in terms of around the over 60 kind of area is a key one for us. And we do provide a lot of classes and activities in Wetherby for that, and that kind of falls presentation and the lights that we deliver in that area as well. So there's a lot of stuff going in there, but yeah, the facility itself is something which we need to kind of make improvements on.
Okay, thank you, Councillor Harrington. Okay, yes, Councillor Arif.
Yeah, Chair, just a couple of points. First point, I'm lucky that I've got my researcher Rob in the room. He's answered Dr. Beale's question. We've got 73 outdoor gyms and multi-use game areas and 29 outdoor gyms specifically. So hopefully that will help answer some of your questions. Come back to Councillor Harrington's point about Wetherby. I was having a conversation about investment going into Wetherby only last week. So just be reassured about some of that funding will be directed there because we recognise the points you've made. But just as a general point, I'm sure you've all read headlines about pool closures. 40% of councils across the country are at risk of closing their leisure centres because of financial constraints that councils are facing. And actually in Leeds, we're doing the opposite. We put investment into our leisure centres because we are committed to doing that. But we are against a backdrop of really severe financial cuts, if I may say so. But just to reassure Councillor Harrington that conversations are in place to put some investment in Wetherby. Thank you.
Thank you very much, Councillor Ari, for that reassurance. Thanks. Councillor Thompson.
Probably quite a broad question, but just linking back to previous things about social prescribing and peer support and low cost interventions that could be used, whether with cancer patients in terms of prehab and rehab, young people and all the different sort of, and women particularly, different groups, whether there's anything going on that would be helpful.
Yes, we're just currently working with Macmillan in terms of prehab kind of cancer kind of treatment side of things. So yeah, that's kind of making sure from one stage they're kind of ready for any kind of surgery elements that you might need to go to, in the hope that they recover faster and get out of hospital sooner on that front. So we are being commissioned working with Macmillan on that front, which is something which is happening across West Yorkshire in different areas as well, with the ICBs and the like. So yeah, there's a lot kind of coming in terms of that commissioning side of things till they understand that from diabetes to different things that we kind of work with now from that side, that, you know, we are there not only from a prevention side of things, but also from a help to recover people quicker from their illnesses and the likes as well, and hope to redress some of that. So again, it's not going into the medical sphere all the time. So it is a big area for us from that health program side of things to make sure we help on that front.
Okay, thank you very much. I will need to bring that agenda item to a close because of time, but you're not permitted to leave just yet. That's because when you're all leaving, it takes about 2 or 3 minutes of our time and we need to finish up. So just be patient with us. We're almost done. Thank you very much. Okay, so agenda item number 10 is the end of year scrutiny board statement, and each scrutiny board now produces an end of year statement to complement the broader scrutiny annual report. So the 2022 and 23 end of year statement for this scrutiny board has therefore been provided for members' consideration and approval. So the statement document follows a standardized format to provide details of the board's full work program for the first municipal year, including links to the associated agenda packs, minutes and webcast recordings, as well as including a statement from the chair that reflects on the key priorities for the scrutiny board over the year, and that has been shared with each and every one of you. So please do not say to me I haven't read the report, because you'll be in trouble. So I'm just asking members now, are you happy to endorse the end of year statement for this scrutiny board that has been provided by our members? And obviously we've had our 2 exec members in the last municipal year helping us and being here every single scrutiny meeting. So we just want to say thank you to both of you for always being here. So is that a yes from our board members? And with a smile. Excellent. That's very good. So thank you very, very much. I'll now call on Angela to talk through our next work schedule.
Thank you, Chair. There are actually 2 elements to this particular report. The element that I'll address first is where there's reference to the board's recent working group meeting to consider the current positions surrounding the delivery of the Leeds mental health strategy. This was with a view to also identifying key areas that could potentially benefit from more focused scrutiny work during the new municipal year. So a summary of the main issues and the key conclusions arising from the working group meeting has been circulated as part of the supplementary pack. Members are asked to consider the content of the summary note and in particular to endorse the key conclusions, including the 2 proposed recommendations, and that is for the Successor Scrutiny Board to firstly continue closely monitoring general progress with this strategy, but also to undertake a more focused piece of work that aims to assist in the successful delivery of the new community health transformation programme, particularly in recognition of the key benefits that would bring in terms of enhancing a preventative offer. So if I could address that first, Chair, if members are happy to endorse that, the summary note and recommendations. Thank you. And given that today's meeting is expected to be the board's final formal public meeting for this year, the draft work schedule that's been attached is in relation to the new municipal year. This includes preliminary future meeting dates and also reflects known items of scrutiny activities such as performance monitoring, the budget and other identified areas of work that this board's already recommended for the successor board to pursue in the new municipal year. There's obviously other areas that we've picked up today with other suggestions, particularly around a focus piece of work around social prescribing. So we'll reflect that in the minutes because obviously at the first meeting of the new board, they will obviously have these minutes. So if there are any other areas that the board would like to suggest at this stage, then I'm happy to reflect those too. Thank you.
Thank you very much, Angela. Any comments on Angela's item? Okay, may I use this time to say a very huge thank you to all the board members, especially for attending meetings that are outside our statutory meetings. So those are our personal work groups that we have had, especially remote meetings, just to say thank you from the bottom of our hearts for your time and commitment to this scrutiny board, and to all our guest officers, exec members. You have been amazing, especially when it comes to responding to emails and to invites. And obviously, it's been a tough time, especially within the health industry. We know that in the last 3 years, and we continue to see the challenges ahead. But, you know, your resilience and the hard work you put into the hard work you do for this city and ensuring that the poorest, you know, are treated the fastest. That's from your priority. So always remember our motto for the city of compassion, that we continue to take that with us wherever we go, because that's what we owe our future, our children and their children as well. So thank you and thank you. And to the rest of you, have a wonderful, wonderful afternoon. And thank you. It's been a long year, but it's gone by very fast. I can't believe this is the last meeting for this municipal year. Nobody knows what comes next, but whatever comes next, my best wishes. So thank you.